Hello everyone and welcome to the new section of clinical pharmacology as a part of central nervous system clinical pharmacology. Today we are going to speak about antidepressant medication, and we will start speaking about maybe explain the definition of depression, the preference of definition, and what is the sign and symptoms, the causes of depression, any associated problem maybe with the definition with the depression. Then we move on to the treatment options such as cognitive behavior therapy or like medication therapy. We are going to speak about SSRI, SNRI, TCA, typical treatment, and monoamine oxidase inhibitors, MAO, and we move to the group of medications such as selective serotonin inhibitor, then we have serotonin-norepinephrine reuptake inhibitor, SNRI. We are going to speak about TCA, tricyclic antidepressants. Then we move to the monoamine oxidase inhibitor and conclude that with a typical antidepressant. Okay, antidepressant clinical pharmacology. We start with the definition. Definition of of depression, considered like a mental health disorder characterized by the depressed mode or loss of interest in activity, causing significant impairment in daily life. The preference, according to the CDC, they said is estimated 21 million adults in the United States at least suffer from one major depressive disorder or episodes, and the number represented like 8.4 of all adults in the US suffer from depression. According to the symptoms here, patients suffer from depression may present with the symptoms such as sadness, hopelessness, inability to experience pleasure in usual activity, a change in sleep pattern, a change in the appetite, losing energy, and suicidal thoughts. Here, very important things we need to maybe indicate to the depression may associated with the suicidal thoughts. At the same time, most of the antidepressant medication associated with the suicidal increased risk of suicidal thoughts. So we have some overlap between the disease may cause suicidal thoughts and the medication may associate with the suicidal thoughts. Causes is not clear for us, but we have some factors may play important factors for to precipitate in the depression, such as genetic factor, biological factors, environmental factor, psychological factors. This one will be more details in the for example, in the clinical medicine and diagnostic testing, in the differential diagnosis. So we have so many factors may predispose to the depression: genetic, biological, environmental, and psychological factor. The depression normally associated with the decreased level of mediator, could be neuromediators, and one of the most important mediator associated with the depression, decreased serotonin activity, decreased norepinephrine activity, decreased dopamine activity. So three main mediator may be associated with the deficiency in Parkinson disease and depression disease. Sorry. So patients suffer from depression may suffer from or one of these mediator or of these mediator deficiency, the decreased serotonin, decreased norepinephrine, and decreased dopamine, and so on. Okay. Treatment availability for for the depression could be start with the cognitive behavior therapy, ended up with the antidepressant medications such as SSRI, SNRI, TCA, monoamine oxidase, and a typical antidepressant. Of course, we are going to explain all these in details in the next coming slide. about each group of this medication. What is the advantage? What is the disadvantage? How this medication work? Mechanism of actions, clinical use, adverse reaction. All these criteria will be covered. Okay, this slide here summarizes the information we already covered in the previous slide about the definition, for example, about the preference, signs, symptoms, the causes, treatment availability. Okay, as you can see, what type of medication do you have for patients suffer from depression? Start with the first group of medication, SSRI, SNRI, TCAs, a typical monoamine oxidase. Here on the right side, we have the abbreviation. Explain the abbreviation. SSRI stands for selective serotonin reuptake inhibitor. SSRI. SNRI stand for serotonin-norepinephrine reuptake inhibitor. SNRI. TCA stand for tricyclic antidepressant. Then we have a typical antidepressant. We don't have a variation for that. Then we have monoamine oxidase inhibitor, MAOIs, monoamine oxidase inhibitor. So for the maybe simplicity, we have it like five main group: SSRI, SNRI, TCA, atypical, and monoamine oxidase inhibitor. Okay, here we have like a diagram for the medication used in the treatment of depression. As you can see here, we have selective serotonin reuptake inhibitor, SSRI. We have citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, Zoloft. So we have list of medication belong to the SSRI. This is the most popular medication. Citalopram, Celexa, and then we have escitalopram, fluoxetine, Prozac, fluvoxamine, paroxetine, sertraline, Zoloft. What about the SNRI, serotonin-norepinephrine reuptake inhibitor, SNRI? What we have here, the most popular one, we have duloxetine followed by venlafaxine. Then we have this venlafaxine. Then we have levomelanocibran, Fetisma. So all these popular medication belong to the SNRI. We have Cymbalta, Fetisma, Effexor, and Bristec. Again, for SNRI, duloxetine, Cymbalta, venlafaxine. Then we have this venlafaxine, levomelanocibran. Okay, regarding the TCA, tricyclic antidepressant. Okay, as you can see here from the list regarding the TCA, tricyclic antidepressant, we have amitriptyline on the top of this medication, amoxicillin, disobramine, doxybin, imabramine, nortriptyline, clomipramine, anafranil. So we have list of medication belong to the TCA, and we are going to explain what that means for us. Again, for TCA, amitriptyline, amoxicillin, disobramine, doxybin, imabramine, nortriptyline, and clomipramine. Okay. Moving to the next group, we have monoamine oxidase. On the right side here, we have monoamine oxidase. The monoamine oxidase inhibitor, we are talking about phenlizine, tranilsabramine, isocarbozide, and then we have siligilene. Okay, monoamine oxidase, phenlizine, tranilsabramine, isocarboxide, and siligilene, Zoloft. A typical antidepressant, one of the most important group of antidepressant, a typical antidepressant, we have bupropion, the brand name Wellbutrin or Zipan. We have mirtazapine, one is the most important two medication, bupropion and mirtazapine, Remeron. Then we have nafazodone, trazodone, and azodone, and vortioxetine. So we have list of medication belong to the typical, and the most important top medication here bupropion, mirtazapine, nafazodone, trazodone. Okay, so as maybe a summary or recap, so as you can see, we have five main group for depression. Okay, what is the difference between these group? Any idea, for example, how we can differentiate SSRI comparing with the SNRI and TCA? Okay, again, we are going to explain this table. This table is very important for us. As you can see here, we have SSRI, mainly SSRI. I'll go back again. SSRI mainly affect the serotonin reuptake, 4 plus, and 4 plus consider like very strong affinity, 4 plus. If you move to the what happened, what is the effect of SSRI on the norepinephrine? Zero. There is no effect on the norepinephrine. So this medication inhibit reuptake of serotonin. Here we need to remember that according to the definition. So when you have, I need to go to the whiteboard a little bit to maybe explain what happened there. Okay. When you explain this one here, I will say this is the nerve ending. Okay. And this is the neurons, vesicles, and the vesicles lead to the release of mediator. And then we have a receptor here and responsible for reuptake. This is number one. So number one, reuptake. We call this one reuptake process. Number one. Number two, this medication, this particle serotonin here, will bind to the receptor. This is what happened there. Okay, refresh. Okay, postsynaptic receptor. Okay, so when this number two, so the fate for this one, number one, binding to the postsynaptic receptor. Number two, reuptake, and number three will be metabolized by two enzymes. Number one, monoamine oxidase or catechol transferase. This one, speaking in general for the mediators, or what happened to the mediators. Okay, if you look what we have here, again, we covered this one with a similar situation. So we have the pathways. We have the pathways here. This is a mediator here, like blood flow or like nerve flow. Then we have branches. I will clean this one. Again, this is the branches here. Let me say this one represents the reuptake. This one postsynaptic. Okay, and this one represents metabolism. So our medication for SSRI inhibit the reuptake. This will enhance the activity of postsynaptic, enhance the release of mediator, enhance the effect of serotonin. I hope this explains what happened with the reuptake. When you speak about reuptake, so SSRI inhibit, from the name, selective serotonin reuptake inhibitor. So we are speaking about medication inhibit reuptake. That means this will enhance the effect of serotonin in the postsynaptic. So this will lead to the enhanced activity on the postsynaptic. Okay, next group we have SNRI. We have venlafaxine, duloxetine. As you can see here, duloxetine affect both norepinephrine and serotonin equally, like strong, consider like very strong affinity towards this reuptake, inhibit both norepinephrine and serotonin equally. When you talk about duloxetine at therapeutic dose. What happened with the venlafaxine effector? As I said, with the therapeutic dose for venlafaxine, I will clean it a little bit. With the venlafaxine therapeutic dose, Filafaxin. Filafaxin therapeutic dose affect mainly the very strong affinity towards serotonin receptor, serotonin reuptake, and consider like moderate effect on the norepinephrine reuptake with a therapeutic dose. But if you prescribe high doses, that will affect both equally, will affect both receptor equally. Okay, moving to the last group here of medication, TCI, tricyclic antidepressant. TCI, tricyclic antidepressant here. We have imipramine, we have nortriptyline. As you can see here, they affect both receptors, both reuptake, norepinephrine and serotonin. Someone may say, okay, so TCA, someone may say that from this table here, TCA is similar to the SNRI, similar to SNRI. Do you think this is correct? Okay, this one, in the, if you look only on this table, you can say this is correct. If you look on this table only, but this is not correct when you speak about other effect of TCA, because TCA not only affect the reuptake of norepinephrine and serotonin, TCA affect other receptor. So we are going to speak about other receptor will be affected by the TCA. So TCA affect number one, inhibit reuptake norepinephrine, inhibit reuptake serotonin, and also block a lot of receptors such as muscarinic receptor, such as histaminic receptor, and adrenergic receptor. So here with the TCA block several receptor in addition to the inhibit reuptake. We are going to speak about that later on. Okay, when you prescribe a medication, antidepressant to your patient, we need to remember very important principle of treatment here. One, the onset of action of therapeutic need sometimes require like several weeks, and some textbook maybe mentioned that it's between 2 to maybe 10 or 12 weeks to start working. So when you prescribe the medication, you need to tell the patient, the family, the friends, this medication need at least 15 days to start seeing the effect, and sometimes need 1 month or like maybe 2 or 3 months to see the effective treatment for this medication. Okay, here what we have about the diagram to explain what happened there. So before we start speaking about this diagram, this is very important diagram in the clinical pharmacology approach and the clinical pharmacology interaction. I will go back a little bit to show you what we have. We are talking about two main neurons maybe involved in the depression. Two main neurons. Number one, we are speaking about serotonin, serotonergic neuron and adrenergic neuron. So we have two main neurons involved in the pathophysiology of, in the etiology of depression. Okay, as you can see here from this diagram, we have the first one we have serotonin, serotonin neuron, serotonergic neuron. Then we have adrenergic neurons. So we have two main neurons involved in depression. Start speaking about serotonin, and serotonin start from amino acid called tryptophan. Tryptophan convert to the 5-hydroxytryptamine. The 5-hydroxytryptamine enter the vesicles. The vesicles then maybe come to the close end of the neurons, and we have some calcium channel will be open here, and this calcium channels cause like hyperpolarization, digging on the vesicles wall, open the vesicles content and release in the synaptic gap or synaptic cleft. We call this one synaptic gap or synaptic cleft between the neurons and the target or the effector. Okay, you can see here we have the serotonin, this is red cycle here, the serotonin released, and now we have maybe some fate. What happened when the serotonin released? As you can see here, the serotonin, number one, binding to the receptor, both synaptic receptor. You can see the serotonin receptor, both synaptic receptor. This is number one. Number two, okay, the serotonin will go, this number one. The serotonin will be reuptake by the receptor called reuptake receptor or process. And number three, we have enzyme monoamine oxidase. So we have three fates for the serotonin. Number one, binding to the postsynaptic. Number two, reuptake. Number three, metabolized by monoamine oxidase. This process considered like a target for the treatment of depression. Okay, moving to another side to the norepinephrine. Norepinephrine and the gray fascicles here, we have norepinephrine. The blue fascicles represent the serotonin. So the blue color represents the serotonin neurons, and the gray color represents the adrenergic neurons. So speaking about adrenergic neurons here, as you can see, so this adrenergic neuron starts from tyrosine, convert to the DOPA, then DOPA will convert to the dopamine, dopamine enter the fascicles and convert to the norepinephrine. So this a triangle here represents the norepinephrine. Okay, and this circle here represents the serotonin, and you can see it on the neurons. Okay, this mediator, this norepinephrine mediator, release in the synaptic cleft. Okay, and then we have similar situation. This will bind to the postsynaptic receptor, could be alpha, could be beta receptor, and we are familiar with that from the autonomic nervous system. So the norepinephrine bind to the postsynaptic receptor, and what we have here, we have alpha adrenergic receptor. Okay, bind to the alpha adrenergic receptor. Okay, this number one, or the norepinephrine will be reuptake by the another receptor called alpha 2 receptor. This is the presynaptic, or metabolized by the monoamine oxidase. So we have several fate for the similar fates. We have several and similar fate compared between the serotonin and norepinephrine. Okay, this slide here here we are start talking pharmacology, clinical pharmacology. I like this slide. Selective serotonin reuptake inhibitor, SSRI. Okay, the group of medication: citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, Zoloft. How this medication work? As you can see here, this medication, you can see the X here. This medication inhibit the reuptake. Okay, this medication inhibit reuptake. What happened to the mediator, to the serotonin mediator? You see here increased number of serotonin release. Okay, if you go back to the previous slide, you can see here we have limited number of mediator in the synaptic, in the gap. We have limited number. If you counted 1, 2, 3, 4, 5, limited number of mediator there. When we prescribe SSRI inhibit reuptake, what happened to the mediators here? You can see how many is increased number of mediator release in the gap, in the synaptic cleft, and this will enhance activity of serotonin, binding to the receptor and produce the activity, produce pharmacological activity. Again, medication used as SSRI, we have citalopram, escitalopram, fluoxetine, Prozac, fluvoxamine, paroxetine, and sertraline, Zoloft. So how this medication work? This is a group of medication selectively inhibit the reuptake of serotonin and the presynaptic neurons. Okay, so you can see the X here mean inhibit, and from the name here, inhibit reuptake. Okay, moving to the next group of medication. How the next group of medication work? Okay, so the next group of medication, we have serotonin, norepinephrine reuptake inhibitor, SNRIs, serotonin, norepinephrine reuptake inhibitor, SNRIs. How this medication work? You can see the arrow here, and this medication work on two main target. This medication work on two main target. Number one, from the name serotonin, this medication inhibit reuptake of serotonin. You can see the X here. Number one, inhibit reuptake of serotonin. Number two, inhibit reuptake of norepinephrine. So we have two target: inhibit serotonin reuptake and inhibit norepinephrine reuptake. Okay, group of medication belong to this this class here of SNRI. So we can have it here like prototypes: Cymbalta, duloxetine. Then we have venlafaxine. Then we have this venlafaxine, and they have levomelanocibram, Fatisma as a medication. We have another medication we are going to mention later on. So Here, this makes sense for us how this medication work. SNRI is work on two type of neuron: serotonergic neuron, adrenergic neuron, blocking the reuptake for both serotonin and norepinephrine reuptake. Okay. So we're done with the first group. So we discussed with the second group. We discussed the first group with you. The first one was SSRI. It's very clear here. Move to the second group. SNRI work on two neurons, adrenergic and serotonergic neurons. Okay, then we move to the next neurons. Okay, the first group was SSRI, the second group was SNRIs, and the third group will be tricyclic antidepressant TCA. So for the regarding the TCA, here we need to mention regarding the TCA, we need to mention we have a group of medication. We have amitriptyline, amoxicillin, disabramine, doxybin, imipramine, nortriptyline, and clomipramine. So anafranil. So we have list of medication belong to the TCA, tricyclic antidepressant. The question now, how this medication work? So we ask ourselves how this medication work. We need you to follow with me the process about TCA mechanism of action, how the TCA work on the central nervous system for the human body. I will start maybe talking about one by one. We have 5 mechanism of action. We have 5 target for the TCA. So if someone may say, okay, TCA is not selective. TCA is like a group of medication. This group of medication is this group is not selective in working because this medication affects several target in the central nervous system. We don't prefer to use this medication because of the it affects several target in the brain. I will start speaking about this one. Number one, TCA, as you can see the X here, inhibit the reuptake. This is number one. Reuptake of serotonin. Number one. TCA inhibit reuptake of serotonin. Okay, number one. Number two, TCA inhibit reuptake of norepinephrine. This is similar to the SNRI. Okay, what else? TCA also, you can see here, bind to the adrenergic receptor and block adrenergic receptor. You can see the X here. This is number 3. Number 4, so blocking adrenergic receptor. Number 4, TCA block muscarinic receptor. Okay, you can see number, so 1, 2, this is 3. Okay, this is number 4. And then again, in addition to this 4, we have number 5, TCA block histamine receptor. So we have 5 mechanisms explain the effect of tricyclic antidepressant medications. Number 1, a block serotonin reuptake, a block norepinephrine reuptake, inhibit adrenergic receptor, alpha adrenergic receptor, inhibit muscarinic receptor, and inhibit the histamine receptor. So we have 5 mechanisms, and this explain 2 things. Number 1, explain the activity and therapeutic use of TCA, and number 2, and the number 2 is most important, the most important than number 1. Number 2, explain the adverse effect of TCA, or like precautions and warning coming from the TCA. As you can see here, TCA is not selective. TCA inhibit reuptake of serotonin, inhibit reuptake of norepinephrine, block adrenergic receptor, block muscarinic receptor, block histamine receptor. TCA is a group of medication which is not selective medication. We don't recommend to use it on regular basis. The first drug choice of use, first line therapy for patients from anxiety or from depression or major depression will be SSRI, such as fluoxetine, Prozac, or we group of medication belong to the SSRI. Okay, next group will be number 4. So we already covered number 1 SSRI, number 2 SNRI, number 3 TCA, number 4 monoamine oxidase inhibitor. So monoamine oxidase inhibitor here we have medication name phenlizine, tranithromine, and we have isocarboxide. Then we have silidine, we have Zoloft, or other name AMSAM. So what we have so far here, we have Again, we have monoamine oxidase in both serotonin receptor, serotonin neurons, serotonergic, serotonergic neurons, and adrenergic neurons. We have monoamine oxidase in both. Okay, you can see here we have the enzyme, and this enzyme, monoamine oxidase, from the name ACE, here we are talking about enzyme. When you have ACE, we are talking about enzyme. For example, when you say ATPase, here we are speaking about enzyme. When you say transaminase, here we are speaking about enzyme. When you have A's at the end, we are speaking about enzyme. Monoamino oxidase, we are talking about enzyme. So remember, this group of medication inhibit monoamino oxidase, and this monoamino oxidase is responsible for metabolism of several mediators, not only two. One of the most important mediator we have it here, responsible for metabolism of serotonin and norepinephrine. Okay, metabolism. So if you inhibit the metabolism, what happens? This will enhance the activity, increase the activity or increase release of norepinephrine and increase release of serotonin on the synaptic cleft and postsynaptic neurons. Enhance the activity of both mediator. Okay, now this explain what happened with these two medication here. Okay, this table here consider one of the most important table in the antidepressant medication. Okay, speaking about this table, which I mentioned already, is one of the most important table for the discussion and understand the topics of antidepressant. Antidepressant class here we cover the SSRI. We have SSRI, SNRI, TCA, monoamino oxidase. That's a very important table. So the question here, which of these medication mainly affect the serotonin? Mainly affect the serotonin. So we have SNRI. Which of these medication affect both serotonin reuptake and norepinephrine reuptake? We have SNRI. So which of these medications selectively inhibit the reuptake both serotonin and norepinephrine? So SNRI. Which of these medication inhibit norepinephrine and serotonin, but it's not selective? They block other receptors. So what we have here, we have TCA. As you can see here, TCA, mebramine nortriptyline, not only inhibit the reuptake, 1, 2, this is number 1, this is number 2, inhibit reuptake, number 3, block muscarinic receptor, number 4, block histaminic receptor, and number 5, block adrenergic receptor. And this explains the adverse effect and side effect from the TCA. Last one, monoamino oxidase. Okay, speaking about monoamino oxidase here on this table, I like what we have here, 0, 0, 0, no effect. Monoamino oxidase, there is no direct effect on this medication on this receptor, on this component here. Monoamino no effect on the reuptake and serotonin and norepinephrine, no direct effect on the muscarinic receptor, adrenergic or histaminic receptor. Okay, that's good. So what happened with the monoamino oxidase? We need to look maybe to the notes here. They said monoamino oxidase, when you inhibit this enzyme, this will lead to the increased release of norepinephrine and increased release of serotonin. Does that make sense for us? So monoamino oxidase is a medication, monoamino oxidase inhibitor is medication used to inhibit metabolism of norepinephrine and serotonin. And this will lead to the increased release of these mediators in the synaptic cleft and enhance activity. Okay. Okay, tricyclic antidepressant. Here we start talking about a group of medication one by one in some details in clinical pharmacology, advantage, mechanism of action, uses, adverse effect. Okay, I will start with the first group of medication, tricyclic antidepressant. I believe that you are now familiar with how this medication work. I will start with the mechanism of action, TCA, tricyclic antidepressant, TCA and tricyclic antidepressant, mechanism of action. Okay, number 1, inhibit reuptake. You tell me that. How this medication work? Inhibit serotonin reuptake, inhibit norepinephrine reuptake in the presynaptic neurons. This is number 1. Number 2, block receptor. What type of receptor? They said block receptor of serotonin alpha adrenergic, histamine, and muscarinic receptor, and this blocking of these receptors responsible for adverse effect. Okay, which of the following responsible for the tricyclic and the antidepressant adverse effect? So there will be the blocking the receptor, muscarinic, adrenergic, histaminic, and muscarinic receptor. One medication in this group will be amoxicillin. Amoxicillin not only blocking the serotonin receptor, we have specific type, the serotonin receptor 2, and also block the dopamine receptor D2, dopamine receptor in the neurons. So amoxicillin has some advantages or characteristic different from the traditional TCA, blocking serotonin receptor 2 and dopamine D2 receptor. Okay. What happened here? We prescribed this medication to the patient. What is the action of this medication? Is there any positive, negative effect? So what happened? We have some instruction, guidelines. Okay, we can provide some information. Number one, when we prescribe this medication to the patient, we are going to see improved mood in about 60% of individual. Between 50 to 70% of the individual will be suffer. Maybe you can see the improved mood and maybe improve the major depression and relieve the symptoms of major depression. Okay, this medication, when you prescribe this medication to your patient, you have to be patient and you have to tell the patient, educate the patient about the medication. This medication need more at least 2 weeks to see the effect of this medication. This medication has a slow onset of action. So any medication in this group needs time, 2 to 3, 4, 5 weeks sometimes to see the action, the effect of this medication. Number 3 is also very important here. It's very important to stop this medication gradually, because if you stop this medication suddenly, the patient may suffer from discontinuation syndrome and cholinergic rebound effect. So this medication, if you can see here, block the muscarinic receptor. This medication blocks the receptor. If you stop this medication suddenly, the muscarinic receptor will be activated and the patient will suffer from cholinergic rebound effect. Okay, the clinical use. We have tricyclic antidepressant medication, and someone maybe try to remember less of medication belong to this group. We have imipramine, amitriptyline, nortriptyline, amoxicillin, list of medication. We have this medication, this group of medication used for depression, treatment of depression, panic disorder, bedwetting in children, preventing migraine and headache, amitriptyline, and could be used for treatment of chronic pain condition such as diabetic neuropathy. We can use amitriptyline. Insomnia, doxepin. So we have one of these medication may be available there. So if the patients are from insomnia and we need to use any medication from the TCA, drug of choice will be doxepin. So TCA, doxepin will be used for insomnia. TCA, amitriptyline used for the neuropathic pain. TCA, amitriptyline, we can use it for migraine prevention. Amitriptyline could be used for children suffer from bedwetting during the childhood between the less than 12 years old. Panic disorder, depression. Here for the depression, here is not first choice. You place your patient on SSRI. If the patient does not respond to the SSRI, the other option will be a TCA. So the first option will be SSRI, and the TCA will be other choice, other option, not the first line therapy. This is the first line therapy for the depression. This is the first line therapy for the anxiety. Okay, moving to the adverse drug reaction and drug interaction. So speaking here in the slide, we are going to speak about adverse drug reaction and drug interaction. Okay, speaking about the TCA, adverse drug reaction and undesirable effect or unwanted effect, drug interaction and other precaution warning. So number one, the TCA, if the patient take overdose of TCA, and this will lead to the death or consider like life-threatening cardiac arrhythmia. So overdose of TCA, this will lead to the death or lead to the life-threatening cardiac arrhythmias, and we don't have antidote. We don't have antidote for TCA. Okay, so this number one. Number two, this medication, TCA, in general, amitriptyline, nortriptyline, amoxicillin, doxybin, black muscarinic receptor. Black muscarinic receptor, RS stand for receptors. A black muscarinic receptor. This medication cause atropine-like adverse effect. So if someone maybe ask, what does that mean, atropine-like adverse effect? We need to remember what are the cholinergic effects are. So when you enhance cholinergic neurons, what happened? And when you speak about atropine, black muscarinic receptor will be the opposite effect of acetylcholine. So atropine would cause dry mouth. Atropine cause blurred vision. Atropine caused bradycardia. Atropine may aggravate the prostate enlargement. Atropine may cause urinary retention. So we have several maybe side effects coming from the atropine. Dry skin. Okay, so we have several maybe side effects, many side effects related to the atropine, and TCA cause atropine-like adverse effect. Moving to the other effect here, we know that TCA, a black alpha adrenergic receptor, and this, when you block alpha adrenergic receptor, this will cause vasodilation. So here we recommend maybe the student to go back and maybe the audience to go back and review what happened on the autonomic nervous system a little bit. So I will go to the whiteboard again, like a quick review regarding this issue here. So on the blood vessels, I'm not going to discuss details here because I recommend you to go back and review the autonomic nervous system. We have something called adrenergic neurons, and we have cholinergic neurons. Adrenergic neuron, the main mediator will be norepinephrine and epinephrine, and then for the cholinergic we have acetyl. Speaking about acetylcholine, I don't know what happened there. Give me 1 minute. Okay, so for the cholinergic neurons, we have the main mediator acetylcholine. Okay, speaking about acetylcholine, we have two main receptor. We have muscarinic receptor, then we have nicotinic receptor. For muscarinic, we have M1 to M5 receptor. For nicotinic, we have NM and we have NN. And it's not our topic for now, but we can do it for the autonomic nervous system later on. Okay, regarding alpha receptor. Okay, regarding adrenergic neurons, talking about adrenergic neurons, we have beta receptor, then we have alpha receptor. For the alpha receptors, we have alpha 1 receptor and alpha 2 receptor. Alpha 2 receptor mainly available in the pre-synaptic neurons. And here we are talking about central nervous system mainly. So alpha 2 receptor available in the presynaptic neuron mainly, but we have it in some other places. Alpha 1 receptor, the main location for alpha 1 receptor will be in the blood vessels. Okay. And the reason for this explanation, so alpha 1 receptor mainly available in the blood vessels. What about beta receptor? Here I'm talking about only about blood vessel. I'm not going to speak about the heart. In the blood vessels, we have beta 2 receptor. Okay, in the blood vessels we have beta 2 receptor. Now, okay, moving a little bit to speak about in the blood vessels, as you can see, we have alpha 1 receptor and we have beta 2 receptor. For to speak about adrenergic here, adrenergic receptor, we have alpha 1 receptor and beta 2 receptor. As you can see here, we have you can imagine here we have scale and we have balance. So we have balance between both of them, alpha 2 and alpha 1 and beta 2. Okay, so what happened there if you, the effect there on the, speaking about this medication, they said if you activate alpha 1, the result will be vasoconstriction. And this will lead to the increased peripheral vascular resistance, and the end result will be increased blood pressure. This is number one. Okay, what happened here with the beta 2? If you activate beta 2 receptor, the result will be vasodilation and decrease peripheral vascular resistance, and the end result will be decreased blood pressure. So we have in the human body, in the normal physiological life, as you can see here, we have balance between both of them, alpha 1 and beta 2. Okay, so here we have the opposite. What happened if what we can see here, we have stimulate. What happened if you block alpha 1? The result will be the opposite. So if you block alpha 1, so here I will maybe do the other option here. I have alpha 1 and alpha 1 receptor, and I block this receptor. The result, if you block alpha 1, the result will be, instead of vasoconstriction, we are going to see vasodilation. Okay, decrease peripheral vascular resistance, and this will lead to the decreased blood pressure. Here, this decreased blood pressure will be sudden decrease, and the patient suffer from something called hypotension. And this will be like orthostatic hypotension, when the patient changes their position from supine to standing, or from sitting to standing. They start suffer from something called orthostatic hypotension, or positional hypertension, hypotension. So the blood pressure will be decreased. We recommend patient to change position slowly, or recommend to take this medication at night before sleep. Okay, I will move back again to the slide to share with you what happened with this long explanation. Okay, we need to go back. Alpha adrenergic receptor blockade. Alpha adrenergic receptor blockade. The result will be orthostatic hypotension. Now we understand why this medication causes hypotension, because blocking alpha 1, and this also associated with the reflex tachycardia. The same situation will be applied, and this one will be like reflex arcs. And I recommend you to go back and review the autonomic nervous system, because it's not our topic for today to explain why, if you block alpha adrenergic receptor, will associated with the reflex tachycardia. Okay, moving to the next one, histamine receptor blockade. So when you block histamine, the result will be sedation and relief anxiety, induce hypnotic effect. The patient with TCA gain weight, so this may be common side effect, increasing weight. When you treat patient who suffer from depression, you need to take the weight of the patient in consideration. If the patient suffers from obesity, try to avoid this medication, because this medication associated with the gain weight, or the increased weight. We don't recommend it to the patients from obesity, TCA in general. So, but if the patient come to the clinic suffer from anorexia and decreasing weight, this medication could be a good option for the patient, because this medication associated with the increased weight. Okay, this medication TCA also may cause sexual dysfunction. We need to remember that. But they said this sexual dysfunction is lower than SSRI. SSRI cause sexual dysfunction. If you type here, I will type here 3+ for sexual dysfunction. I will go with the TCA like 1+. So sexual dysfunction with the TCA 1+, like moderate to mild sexual dysfunction effect, but SSRI 3+. That mean could be moderate to maybe high sexual dysfunction incidence. Okay. Moving to the next one, it's an important one. As you from the beginning here, the toxic dose, effective dose. They said this medication, this group of medication carry the risk of toxicity due to the narrow therapeutic index. narrow therapeutic index, any change in the concentration of the medication. If you prescribe 5 to 6 fold maximum dose, this will lead to the lethal effect, and this may carry the risk of suicidal risk, and we need to prescribe limited quantity and closely monitoring the patients. So this is very important to remember. When you say narrow therapeutic index, again, I would like to explain what that means for us. For the narrow therapeutic index, we have this graph here, and this graph represents the concentration, plasma concentration, and we have two levels. The first level of the drug level here will be minimum concentration, and the next one will present maximum concentration. Okay, if this is a blood concentration, here represent blood concentration. So we measure the blood concentration of medication. Here we have the range. Okay, if we hope our medication will be in this range between the minimum and maximum. We call this one therapeutic index. Our medication need to be in this range or this window, or we can call this one index, or other textbook they say we call this one like range. So therapeutic range, therapeutic window, therapeutic index. So we need the medication to be between these, between minimum and maximum effect. Okay, the question now, if the concentration, this is drug concentration, if the drug concentration was below the minimum, so this is therapeutic effect. You agree with me? This represents the effect of medication. Effect. Okay, what happened here? Therapeutic effect. If the medication concentration was here and this, okay, this we call this one sub-therapeutic effect. Or sometimes we call this one no effect. It's not enough effect. Sub-therapeutic effect or no effect. Okay, that's good. If the concentration of medication above the maximum here, if the medication here above the maximum, I will go with the red one. If the medication concentration here in this level here, this represents the toxic effect, or ADR, adverse drug reactions. So you can see now we have three levels: toxic, therapeutic, subtherapeutic. Okay, moving to what happened here from this graph here, you can maybe imagine this graph. Okay, this for normal. Okay, moving to the for the TCA, they said this is a minimum and this is a maximum here. This is a minimum concentration, this is maximum concentration. Someone can tell me what happened here. You see this window here? Maybe everyone will maybe say this is narrow. This is narrow window. What that mean with a narrow therapeutic index or narrow window? That mean any change in the concentration of medication up or down will lead to the toxicity or no effect. Okay, so this explains what happened with this group of medication. So when you say narrow therapeutic effect, any change in the drug concentration, any small change in the drug concentration may predispose patient to the toxic effect or no beneficial effect or no therapeutic effect. Therefore, monitoring the medication is very important. We call this one in the pharmacology therapeutic drug monitoring. So I hope maybe you have the opportunity to copy this one, TDM, therapeutic drug monitoring. Google it, and they give you a list of medication that need monitoring. Not only prescribe the medication and leave the patient go home. You need to follow up with the patient education. For example, digoxin, phenytoin, mabramine, warfarin. A group of medication need to be monitoring during the therapy because this group of medication has a narrow therapeutic index. Okay, last one here, we have TCA. TCA, this group of medication, we have monoamine oxidase. They said this combination considered like contraindicated. We don't recommend to use these two medications together, group of medication, TCAs and monoamine oxidase, because both of them enhance serotonin level in our body. When the serotonin level increase, we call this one serotonin syndrome. So because both of them enhance serotonin, increase serotonin, and cause serotonin syndrome, and may cause also hypertensive crisis, and this considered like life-threatening. So as you can see here, we have two life-threatening. Number one, from toxic effect, we have life-threatening, okay, because we have narrow therapeutic index. Number two, combination TCA with monoamine oxidase will lead to the serotonin syndrome and this life-threatening side effect also. Okay, so we're done with the first group of medication belong to the antidepressant. Okay, before we move to the next group of medication, this slide here only to remind you how the number one, this slide here to remind us what the group of medication belong to the TCA, tricyclic antidepressant. We have a group of medication start with amitriptyline, amoxicillin, doxepin, imipramine, clomipramine. This is number one, the list of medication. Number two, the site of action. As you can see, we have 5 site of action. Number one, inhibit reuptake of serotonin in the presynaptic neuron. Number two, inhibit norepinephrine reuptake. Number three, block adrenergic receptor, block alpha adrenergic receptor. Number four, block muscarinic receptor. Number five, blocking histamine or histaminergic receptor. Okay, the second group of antidepressant, we have monoamine oxidase inhibitors. Monoamine oxidase inhibitor here, from the name oxidase, when you see oxidase here, we are talking about enzyme, and our medication inhibit this enzyme. So this enzyme, monoamine oxidase, found in the mitochondria and the nervous system, and the GI system and the liver. It's not only in the brain, not only in the neurons, we can see it in the gut and the GI system and the liver. This enzyme, monoamine oxidase, responsible for metabolism of norepinephrine, serotonin, and dopamine. Okay, this enzyme, if this group of medication, monoamine oxidase inhibitors, irreversibly inactivate the enzyme, and this will lead to the increased stores of these transmitters, and that neurotransmitter will be diffusing into the synaptic space. Okay. Again, this number one. Number two, they found this enzyme also helped for the metabolism of some substance coming with the food, such as tyramine, and tyramine considered like protein or amino acid found in certain food. So this enzyme is important for metabolism of tyramine. So when you inhibit this one, this will lead to the increased level of norepinephrine. We are going to speak about that later on. So our medication, monoamine oxidase inhibitor, this medication inhibits the enzyme everywhere, inhibit the enzyme on the nerves, inhibit the enzyme in the GI system, inhibit the enzyme in the liver, not only in the brain, but everywhere. And this will lead to the drug-drug interaction, drug-food interaction. So monoamine oxidase, for this reason here, considered like, we believe it's like considered like non-selective medication. Okay, this will lead to the increased level of, okay, you can see here increased level of norepinephrine, increased level of dopamine, and increased level of serotonin mediator. So this is number one. Number two, the possibility of drug-drug interaction, because monoamine oxidase we have it in several places, in addition to the interact with the food-drug interaction. Okay, monoamine oxidase, we have 4 medications, as you can see here, currently available 4 medications for the treatment of depression. We have phenlazine, tranithromine, and isocarboxide, considered like monoamine oxidase A. Okay, then we have monoamine oxidase B inhibitor. We have selegiline, Zoloft, monoamine oxidase B. We have 1 medication, and this medication used to treat Parkinson's disease. So I refer you to the Parkinson's disease treatment with the previous lectures, speaking about selegiline for the monoamine oxidase B. So our topic today will focus on the medication used for the depression. We have phenlazine, for example, tranithromine, carboxide. Okay, Use this medication is limited, so we don't prefer to use it. Limited. This medication has limited use, and the reason because we have a complicated dietary restriction. We need to give the instruction to the patient to maybe restrict eat some food. In addition, we know that all the medication on all antidepressant medication need several weeks. Some of them 2 weeks, some of them 10 weeks, or 12 weeks to start seeing the effect of this medication. Monoamine oxidase indicated for patients suffering from depression who are unresponsive, responsive, or intolerant to the other medication. So the first group, the first choice for depression, SSRI. So the second, I will go with the SNRI. Then other option, I will go to the TCAs. So the last option here, last option will be monoamino oxidase inhibitor. Not sorry, I have to type it again. I have to last of monoamino oxidase inhibitor, last option. So the first one is SSRI, SNRI, TCA. Someone maybe can type here atypical. So we have several approaches, several possible solution for patients suffer from depression. Start with SSRI, SNRI, atypical, TCA, and the last option will be monoamino oxidase due to the drug-drug interaction and drug-food interaction. And you can see here different color bold. That means very important, not the first line. Monoamino oxidase, last line therapy for patients suffer from depression. Okay. Here we have this slide here to explain, and we have the link here, the citation and reference for us. Monoamino oxidase drug and food interaction. Normally, when you use it without any instruction for the patient may suffer from severe side effect, unpredictable side effect. Example: tyramine. Tyramine is like amino acid found in some type of food such as aged cheese, meats, liver, pickled, smoked fish, red wine. We have tyramine there. The tyramine normally, when tyramine arrives to the GI system, tyramine in the GIT system, metabolized by monoamino oxidase. Okay, so the tyramine metabolized by the monoamino oxidase. If the patient suffers from depression and you prescribe monoamino oxidase inhibitor, that means you are going to inhibit metabolism of tyramine. Okay, so if you inhibit the metabolism of tyramine, the tyramine will lead to the increased release of large amount of storage catecholamines from the nerve terminal. So tyramine stimulate catecholamine release from the neurons. And when you have norepinephrine catecholamine released, catecholamine mean two main mediator, three mediator here. We have norepinephrine, we have epinephrine, and then we have dopamine. So we have three main mediator will be increased release in the synaptic due to the tyramine stimulate this mediator, norepinephrine, epinephrine, dopamine. What happened to the blood pressure? Increased blood pressure. The patient may suffer from hypertensive crisis. Okay, it's very important. You can see the educated patient here. Patient education, very important step. Patient must be educated to avoid tyramine containing food. Okay, again, what else? They said SSRI should not be administered with the monoamino oxidase due to the risk of serotonin syndrome, already covered with the, for example, TCAs and monoamino oxidase inhibitor. This will lead to the serotonin syndrome. So TCA, monoamino oxidase, lead to the serotonin syndrome. Monoamino oxidase and SSRI will lead to the serotonin syndrome, and we don't prefer to use it. If we need to place the patient, prescribe the SSRI to our patient, we need to give a period of wish out period of at least 2 weeks before you switch the patient from one medication to another. So if the medication on phenlazine and you need to stop this medication for 2 weeks at least, then you place the patient on the new medication. So stop the medication and switch to another medication with at least with the interval of 2 weeks, could be more. Okay, So we're done with the second group of medication. The first group we discussed the first group we discussed TCA, and the second group monoamino oxidase inhibitor, and the third one will be SSRI, the drug of choice. First line therapy, the third group. SSRI, selective and safer option for depression. You can see we have fluoxetine, uh, Prozac, citalopram, escitalopram, fluvoxamine. Then we have paroxetine, sertraline. So we have list of medication belong to the SSRI, which is SSRI stands for selective serotonin reuptake inhibitor. Okay, precise targeting. What that means? Precise, selective. This medication selective in their work, mainly work on the serotonin receptor. There is no effect on other receptor, and this is selective mean accurate, precise effect. Number one, but by this precise effect, this associated with the reduced side effect. We have less side effect because we don't have effect on the other receptor, for example, or other uptake, reuptake. Okay, this medication, SSRI, first line therapy for the patients suffer from the depression due to the safety profile and effectiveness. Two things, first line therapy for depression due to the safety profile and effectiveness. Okay. This medication also need at least 2 to 12 weeks to see the effect. So this one from 2 to 12 weeks to start seeing the effect of this medication. And we have the link here. We can click on the link and bring the medication for you for a quick review together. Okay, so we can maximize it here a little bit. Okay, this medication, Lexapro, we have escitalopram tablet and available as solution, approved by the FDA 2002. You can see it here, and you can see the warning here. The most of antidepressant medication carry the risk of suicidal thoughts, and the antidepressant medication increase risk of suicidal thinking and behavior. This is important issue here. Okay, and especially they say they may be seeing that in the children, adolescents, and young adults. Medication use, you can see it. What we have there, major depressive disorders. I cannot write on that. So major depressive disorders in adult and adolescents 12 years and above. Treatment of generalized anxiety. So citalopram, major depressive disorder, and generalized anxiety. Okay, this is the medication here. I'm not sure if we have anything else to discuss it with you. You can see monoamino oxidase here. They said it's not allowed to use monoamino oxidase with the SSRI. Okay, I will close this one back again to our group medication. SSRI, selective and safer option for depression. A group of medication: fluoxetine, citalopram, fluvoxamine, paroxetine, sertraline. Okay, therapeutic uses for this group of medication. We use this medication for depression. Consider like first line medication, depression, major depression, obsessive compulsive disorder, fluoxetine, sertraline, for fluvoxamine, approved for use in children, obsessive compulsive disorder, panic disorder, anxiety disorder like generalized disorders, post-traumatic stress disorder, premenstrual dysphoric disorder, bulimia nervosa, and premature ejaculation. This is the therapeutic use of the SSRI. So I will click on this link here to show you what we have for the medication and the clinical use for the approval. So I will repeat it: major depression disorder, obsessive disorder, panic disorder, general anxiety, post-traumatic stress, premenstrual dysphoric disorder, bulimia nervosa, and premature ejaculation. This is a Prozac, fluoxetine, sorry. So you can see for the Prozac, fluoxetine available. So Again, for suicidal, increased risk of suicidal thinking, increase for the black box warning, and children, adolescent, and the young adult. Indication very important. Number one, major depressive disorder, MDD. Number two, obsessive compulsive disorder. Number three, bulimia nervosa. Number four, acute disorder, panic disorder, and could be used for another maybe combination with olanzapine, antipsychotic medication for other maybe cases. So it's not our topic today, but we need you to focus on the MDD, major depressive, compulsive disorder, general anxiety. It's a very important one. Here we have very important maybe topics to cover. If you remember, okay, I will maybe remind you, TCA cause weight gain, and very important here, SSRI decrease weight. And if the patient suffers from obesity, okay, bulimia nervosa, okay, this is a medication here, because this medication decrease weight, decrease appetite. Okay, adverse effect, regarding the adverse effect. Okay, regarding the adverse effect, as you can see here, we have the common side effect. Could be anyone maybe suffer from this side effect. The patient may suffer from when you maybe prescribe SSRI to your patient. The patient may suffer from headache, sweating, anxiety, agitation, hyponatremia, nausea, vomiting, all these disturbances. That's fine. But the emergency situation will be serotonin syndrome here, especially when you maybe combined with the monoamine oxidase inhibitor. This will lead to the serotonin syndrome, and also this will lead this group of medication may increase risk of suicidal thoughts in children and young adults. Okay, we need to address the specific topics here. It's very important for us because depends on the situation. We are going to select the medication. For example, here, what they found later on, this medication cause sleep disturbances. This medication cause sleep disturbances here. As you can see, this medication, paroxetine, fluvoxamine, cause sedating effect. Okay, so sedating effect, they said if the patient suffer from difficulty sleeping, we can use this medication, because if you have difficulty sleeping, paroxetine, fluvoxamine facilitate sleeping, enhance sleeping. So because this group of medication cause sedating effect, we have paroxetine, fluvoxamine. That's number one. If the patient suffer from excessive somnolence, for example, here they said activating SSRI, fluvoxamine, sertraline are more activated. This causes stimulation to the central nervous system. So SSRI stimulate the nervous system. So if the patient suffers from somnolence or drowsiness, so the medication will be fluoxetine, Prozac, and sertraline for the patient. So we have two cases here. Number one, patients suffer from depression and difficulty sleeping, paroxetine, fluvoxamine, the drug of choice. Patients suffer from somnolence and drowsiness, and patient need to be awake and active. So we have fluoxetine and sertraline. Again, for sexual dysfunction, this medication may cause decreased libido in about 50% of patients, delayed ejaculation, about 35% of user, and from this delayed of ejaculation, we use it for patients suffer from premature ejaculation at therapeutic uses, anorgasmia, 35% of user may suffer from anorgasmia. Okay, overdose of and serotonin syndromes, SSRI. They said that citalopram with the overdose may lead to the QT prolongation. Okay, citalopram may lead to the overdose, lead to the QT prolongation, seizure with the most of the antidepressant can lower the seizure threshold. Serotonin syndrome when you combine between the SSRI with the monoamine oxidase or other highly serotonergic drugs. We don't recommend to stop this medication suddenly because there is a risk of discontinuation syndrome upon the sudden cessation of this medication. So QT interval with citalopram, most of the medication may cause seizure. Serotonin syndrome when you combine between SSRI and monoamine oxidase, and we recommend the patient and healthcare provider to stop this medication gradually because abrupt withdrawal will lead to the discontinuation syndrome and life-threatening. Serotonin syndrome include hyperthermia, muscle rigidity, sweating, myoclonus twitching, muscle twitching, and change in mental status, and even in the changing in the vital sign. Okay, here before we go further to speak about indication uses for the group of medication, we have some abbreviation we need to address for MDD, major depressive disorder, for OCD, obsessive compulsive disorder, BD, panic disorder, post-traumatic stress disorder, PTSD. Then we have social anxiety disorder, SAD. Then we have premenstrual dysphoric disorder, BMDD. Then we have diabetic peripheral neuropathy pain, diabetic peripheral neuropathy pain, DBNP. So the abbreviation here could be used in the text in our slide. So if you need anything, we can go back again to the slide to remind us what type of abbreviation we use it. Okay, this slide summarizes the SSRI. SSRI, we like this slide. This is an important slide for us. Fluoxetine Prozac, depressive, obsessive compulsive disorder, bulimia, panic disorder, post-traumatic, okay, premenstrual, where is that? Premenstrual dysphoric disorders. Okay, moving to the advantages: long half-life, around 5 to 15 days sometimes. So fluoxetine Prozac, long half-life. Is this any benefit for that? Yes. If the patient take this medication and forgot to take the second dose, for example, this is benefit because there is a remain effect on the body, in our body, because this medication remain for 15 days. Long half-life, fluoxetine. Okay, this medication used for anxiety can cause more anxiety. Fluoxetine can cause more anxiety. Okay, what about sertraline, Zoloft? Sertraline, we use it for anxiety. So if you can, so fluoxetine can cause anxiety. Sertraline used for anxiety disorder, social anxiety disorder. Okay, fluoxetine 26-hour half-life, effective in broad range of disorders. Sertraline preferred for patients from depression and anxiety. Sertraline, Zoloft. Paroxetine or Paxil, the same situation, effect in anxiety, higher incidence of withdrawal effect. Citalopram, major depressive disorder associated with the QT interval prolongation. Escitalopram, less, okay, better tolerated than citalopram. Citalopram QT interval prolongation, better side effect, improve the side effect, less side effect. Okay, citalopram for major depressive disorder, escitalopram for depression and general anxiety. That's great. Fluvoxamine for the OCD, social anxiety. Present the significant drug interaction. So all these tables here represent the significant effect of SSRI to take into consideration. The question: which of these SSRI has long half-life? So we have fluoxetine, Prozac. Which of these medication may cause anxiety? Prozac. Which of these medication may use to treat anxiety? So we have sertraline and we have paroxetine. Which of these medication used for the depression and general anxiety? But this medication associated with the QT interval. So we can create several questions from this table here. Okay, next group of medication we have serotonin norepinephrine reuptake inhibitor, and this stands for the SNRIs. Okay, serotonin norepinephrine reuptake inhibitor. Okay, this medication, this group of medication, inhibit reuptake of both serotonin and norepinephrine and lead to the increased concentration of norepinephrine and serotonin level in the synaptic cleft and enhance efficacy. This medication may relieve pain, especially when talk about neuropathic pain, chronic pain. So, for example, backache, muscle ache, or like neuropathic pain. SNRI, unlike TCA, have little activity on alpha and muscarinic histaminic receptor, little or no effect on the other receptor, no effect on the receptor. Therefore, they have fewer side effects compared with the TCA. SNRI may precipitate discontinuation syndrome. Recommended the patient to stop the medication maybe gradually. SNRI may increase blood pressure and or heart rate. I'm not sure if one able to explain why this medication increase blood pressure. Why this medication increase blood pressure? Okay, to maybe explain a little bit, we have SNRIs inhibit reuptake, serotonin and norepinephrine reuptake. This will lead to the increased level of both of these mediator in the synaptic cleft or in the synaptic gap. Okay, and increase effectiveness of this medication, increase effect of serotonin and norepinephrine. You already familiar with the norepinephrine. If you activate norepinephrine, this will activate alpha receptor, and we already explained that this will lead to the increased blood pressure. So due to the activation of alpha 1 receptor, but could be activate also epinephrine and stimulate beta 1, beta 2, alpha 1, alpha 2, alpha 3. All these will be activated. I will go the beta 3 here, not okay, beta 1, beta 2, beta 3, alpha 1, alpha 2. This also will maybe enhance and increase blood pressure. Okay, so this maybe explain why the blood pressure will be increased and heart rate will be increased here with the SNRI, with the group of this group of medication. Okay, so the SNRI, the medication name here, we need to look on the medication name. Okay, the medication name belongs to the SNRI. Here the SNRI again, S. Okay, I will go back. We have SNRI medication. Okay, we have the duloxetine Cymbalta used for major depressive disorder, diabetic neuropathy, fibromyalgia, chronic musculoskeletal pain, venlafaxine, depressive general anxiety, social anxiety, panic disorder, venlafaxine, vatisma. The last one here, milanacibran, we have Savela. This medication is only for fibromyalgia. We don't use it for major depression here. So we have vatisma for the depression, vatisma only for the depression, Savela only for fibromyalgia. That's good. What about the duloxetine? The duloxetine we use for depression and fibromyalgia. So we need to figure out. Now we have a medication, as you can see here, the duloxetine, use it for depression, Fibromyalgia, diabetic neuropathy, that's fine. Broad spectrum, Cymbalta, duloxetine. What about Fatisma and Savela? Fatisma be used for only for depression, and Savela only for fibromyalgia. So we need to look on what we have. I will click on the Fatisma here. You can see the Fatisma. I will click on the Fatisma and bring it to you. Okay, here we have the Fatisma from the pharmaceutical company. I will maximize the pictures here to show you what we have. Okay, Fatisma, levomelanocibran, extended release tablets, suicidal for the warning. All the majority or all the antidepressants carry the risk of suicidal thoughts and behavior, especially in the young people. Indication for Fatisma. Fatisma is selective serotonin-norepinephrine reuptake inhibitor, SNRI, used for the treatment of major depressive disorder. Okay, so what they stated there, Fatisma is not approved for the management of fibromyalgia. So the question now we need to figure out, I will close this one. Okay, Fatisma for the major depressive disorder, not for fibromyalgia. This is very important. So we are not going to prescribe Fatisma for patients from fibromyalgia, but I'm going to prescribe duloxetine. If the patient suffers from depression and fibromyalgia, duloxetine drug of choice, Cymbalta. What about the patient come to the clinic, everything good, no depression or fibromyalgia? Go with the Savela. So Savela, if I click on Savela here, okay, I'll bring it to you for this medication here. Maximize. Okay, this is Savela here, and this is tablet. Again, for this medication here, is this medication selective serotonin norepinephrine reuptake inhibitor, indicated for the management of fibromyalgia. Is not approved for the pediatric patient. So please remember which of these medication used for fibromyalgia. We have there for the duloxetine, you can review it at your own time, and we have the abbreviation here for SAD, BD, MDD, and so on. Okay, so as you can see here, we already discussed several groups with you, and we covered it. Started with the beginning of this group. If you remember, we covered the TCA. We discussed the monoamine oxidase inhibitor, and we covered the SSRIs together. Then we covered the SNRIs, and now we move to the last group of medication, number 5. Move to the last group of medication. Okay, before we move to the next group, this table here summarizes information for us regarding the SNRI. This is the SNRI. I will go there. SNRI, serotonin norepinephrine reuptake inhibitor. We have the duloxetine, Cymbalta, venlafaxine. Then we have dexlansoprazole, we have Savela, Fatisma for depression, Savela for the fibromyalgia, duloxetine, fibromyalgia, diabetic neuropathy, depression. That's great. For the venlafaxine, depression, general anxiety, social anxiety. We don't have a lot of information about half-life, for example. We have some advantages here, effective for fibromyalgia. Which of these medication effective only on fibromyalgia? We have Savela. Savela may associate with the increased heart rate, for example, hyperhidrosis with the Fatisma, sexual dysfunction with the most of these medications. Sexual dysfunction, you can see it. So this medication causes sexual dysfunction, significant sexual dysfunction, and if you remember, delayed ejaculation associated with this maybe medication, delayed ejaculation. Okay, last maybe group of medication used for depression. Last group of medication here, as you can see, we have the a typical antidepressant. I start with the propropium, puropropium, mirtazapine, nafazodone, trazodone, filazodone, and fluoxetine. Uh, this medication, for example, if you look what we have, most of these medications are associated with the increased risk of suicidal thoughts, especially talking about Wellbutrin, Robirobium, increase of risk of suicidal thoughts in the children, adolescents, and young adult taking the antidepressant. Okay, so please remember this list. Again, for the typical antidepressant, we have propionium, mirtazapine, nafazodone, trazodone, filazodone, and fluoxetine. That's a group of medication considered like a typical antidepressant. Okay, bupropion, Wellbutrin, you can see it here. We need some maybe information about the first medication here. Okay, bupropion. We have it here, Wellbutrin or Zipan. You can see here this medication inhibit reuptake of norepinephrine and dopamine. Okay, so this medication, Wellbutrin, bupropion, inhibit reuptake dopamine and norepinephrine. There is no effect on the serotonin here. Please remember that. Bupropion has no effect on serotonin, mainly affect reuptake, inhibit reuptake, dopamine, and norepinephrine. This medication, bupropion, mainly used for patients suffer from major depressive disorder and patients may be willing to quit smoking. This medication, patients willing to quit smoking because this medication considered like useful for decreasing craving and attenuate withdrawal symptom of nicotine in patients trying to quit smoking. So the key word, bupropion, decrease craving towards tobacco, towards maybe cigarette smoking. Continue speaking about the side effect here. The patient may suffer from sweating or sweating, nervousness, tremor, increase the risk of seizure, hypersensitivity reactions. We have some rare case of Steven Johnson and anaphylactic shock. The most important issue associated with the bupropion, if you remember, if you go back to the SSRI associated with the sexual dysfunction, this medication carry the low risk of incidence of sexual dysfunction and low risk of drug-drug interaction. This one reminds us if you compare it versus monoamine oxidase, for example, inhibitor carry the risk of drug-drug interaction, drug-food interaction. Bupropion has less drug-drug interaction. Bupropion, if you compare it with the SSRI, has a less risk of sexual dysfunction, like delayed ejaculation, for example, with the SSRI. Let me click on this link here. Okay, and show maybe share the screen with you to show you what we have here regarding the information for Wellbutrin, bupropion. Maybe again we need to emphasize on the. Okay, let me remove the picture here. We need to emphasize on the side effect or warning increased risk of suicidal thinking and behavior. This medication, Wellbutrin, mainly used for the antidepressant treatment, Wellbutrin, and we don't have anything else. So mainly for it's not stated there, but we need to have a discussion with your patient about decrease the craving for the smoking and help quit smoking. Okay. So advantages: number one, major depressive disorder, decrease craving towards tobacco, low risk of suicidal sexual dysfunction, low risk of drug-drug interaction. Okay, next medication. So the first medication for the atypical bupropion, we have Wellbutrin. Then the second medication, mirtazapine, Romarone. How this medication work? This medication inhibit presynaptic alpha 2 receptor, inhibit serotonin receptor 2, inhibit serotonin receptor 3, inhibit histamine 1, and this may explain the sedative effect of mirtazapine. Okay, mirtazapine does not cause sexual dysfunction. Big issue here. If the patient suffers from depression and you prescribe SSRI to your patient, the patient will come back to the clinic suffer from sexual dysfunction, delayed ejaculation. Okay, the alternative will be mirtazapine because mirtazapine does not carry the risk of sexual dysfunction. Okay, here we need to does not cause sexual. Here we need to maybe correct something here. Instead of function, this one should be dysfunction. This medication does not cause sexual dysfunction. Okay, this medication as side effect may cause weight gain, increased appetite, and sedation. Again, if you click on the link here, you can have more information about the mirtazapine, remeron. So the first one, bupropion, walbetrine. The second one, mirtazapine. You can see here the mirtazapine affects several receptor, alpha 2 receptor, serotonin receptor 2, serotonin receptor 3, and histamine 1. And this explains the sedative effect. But the most important issue, this medication does not cause the sexual dysfunction. This medication does not cause the anti-muscarinic effect. Okay, move to the next slide. Okay, last slide I think here belongs to the atypical. We have nafazodone, trazodone, filazodone, and we have fortioxetine. The first two medication here on the list, you have nafazodone, trazodone, considered like weak inhibitor for serotonin reuptake, antagonize both synaptic 2A receptor, potent for histamine receptor, and this may cause sedation. Trazodone may cause priapism, and priapism mean erection lasting for more than 4 hours or unrelated to the sexual interest or stimulation. So trazodone associated with the priapism. We can click on the link and have the information there for priapism. And nafazodone may associated with the hepatotoxicity. Both are alpha 1 receptor antagonist. Okay, and may cause orthostatic or dizziness. So I will repeat there what we have here: no effect on the serotonin receptor, no effect on serotonin receptor. Okay. Okay. So no effect on serotonin receptor. I will go back. No effect on serotonin, weak inhibitor of serotonin receptor. This medication antagonizes serotonin 2A, black H1, and they said they are both sharing alpha 1 receptor antagonism. And this explains these nafazodone, trazodone may cause orthostatic and dizziness. Okay, so this is what I need here to share with you. I'll close this one. This one for the trazodone. Okay, trazodone, again, there is risk of suicidal thought and behavior. Trazodone for major depressive disorders. Okay, orthostatic hypotension due to the alpha 1 receptor blocker. Okay, let me click on the control F and look what we can see there. Okay, so you can see the priapism here may cause painful and prolonged penile erection. So trazodone. So trazodone maybe has this characteristic or this characteristic. Trazodone may associated with the priapism. Nafazodone associated with the hepatotoxicity. Okay. Filazodone, serotonin reuptake inhibitor, in addition to the inhibit the partial agonist to 1A. With a partial agonist mean could be agonist, antagonist, similar adverse effect to the SSRI. Then we have the fortioxetine, serotonin uptake inhibitor, in addition to the 1A. So here we have some maybe similarity and differences between all these group of medication. They share some of them. For example, here you can see it's like weak inhibitor for serotonin, nafazodone, trazodone. Filazodone is a serotonin reuptake inhibitor, in addition to 1A as a partial agonist. Okay, so partial agonist, in addition to the Furchuxetine antagonized postsynaptic serotonin receptor 3 and similar side effect again. Okay, we maybe conclude our presentation, our lecture with a case study, maybe a simple case study about a patient, a 34-year-old man who was prescribed citalopram for depression and decided that he wants to stop taking the medication. Okay, the patient decided to stop taking the medication. Okay, he is on citalopram and decided to stop taking this medication. Okay, when question, he said that it was affected his sexual performance, and you ascertain that he is also tried to overcome his dependency on tobacco products. So he tried to quit smoking. So he tried to overcome his dependency on the tobacco product. If you decide to institute the drug therapy for this patient, the best choice will be amitriptyline, propionium, bupropion, fluoxetine, imipramine, or venlafaxine. Which of these medication you are going to choose? Amitriptyline, yes or no? It's not amitriptyline. Okay, what about fluoxetine? Fluoxetine cause sexual dysfunction. Imipramine, not the first choice. Venlafaxine, no, no effect on the smoking tobacco. So the correct answer will be bupropion, because the bupropion decrease craving, will decrease craving towards tobacco or smoking. Okay, this will conclude our lecture for antidepressant for today, and we already covered the definition of depression, the preference of the definition, symptoms, causes, what type of mediator will be abnormal in patient with a depression, such as serotonin, norepinephrine, dopamine, and then we spoke about the possible approach of treatment, such as cognitive behavior therapy or medication therapy, such as SSRI, SNRI, TCA, monoamine oxidase, typical antidepressants. Then we discuss every group of medication, how this medication work, where is the side of action of these medication on the neurons, even for the serotonin neuron, norepinephrine neuron, or the dopaminergic neurons, for example. Then we discuss the drug list for each medication, talk about SSRI, SNRI, each medication of this group. We discuss for the clinical use, mechanism of action first, the clinical use, adverse effect, and is there any contraindication, serotonin syndrome, for example, hypertensive crisis, toxic dose, for example, for the TCA, monoamine oxidase. We discuss the food drug interaction. So we cover a lot of topics and a lot of variations under the antidepressant medication. Even though we have some medications not already mentioned in our lectures, could be recently approved by the FDA. So we recommend you to read the recent textbook regarding this issue. At the end, thank you so much for your listening, and I hope to see you again on the next lectures about the central nervous system, clinical pharmacology, and have a great day, everyone.